ever do.
Okay. And what about test immunization studies? As
Never
mentioned
do.
here.
None. That's up to an immunologist. You send somebody. Yeah, nobody. I've never done them.
Okay. Okay. So basically, sounds like you're the one doing the diagnosis for the SID in your hospital. Is there any kind of clear protocol for making a formal diagnosis of SID in your center?
No, it's not. I want to backtrack on that one thing. Now that COVID's out, I've done the COVID antibody test on a number of people who have CLL, chronic lymphocytic leukemia. And sometimes I've done it, and sometimes the patients requested me to do it, and sometimes I've gotten 2 vaccines, and I wanted to see how they respond. So I will backtrack on that one and say occasionally I've done it for COVID.
Okay, so you've done it sometimes for COVID patients.
Yeah, for COVID patients, I've done before starting cancer treatment, because most of them have been vaccinated. So,
okay.
Yeah, so that's a rare case though. But before COVID, I don't think I did it on anybody, that type of thing. Correct.
And would you do that on certain COVID patients, and would you only do that once for those patients?
Yeah, I only do it once. Well, actually, it's sort of it's partially out of curiosity, because it's been reported that people with CLL don't respond to the COVID vaccine. So it's a topic of conversation when the patient comes in. You're talking to you. Have you ever had the COVID vaccine? Yeah, but I still got COVID. Well, let's see what happens. See if you responded. And so we checked the level, and it might be low.
Okay.
So there are cases.
Okay, but when it comes to diagnosing, just you said is there a clear protocol in your center for actually diagnosing SID, or is it just your?
No, there is not. It's a good question, but there is not.
Okay, so I'll just quickly talk about treatment. So is it just IVIG that you would use to treat your SID patients, or would you ever treat them with like IG radiotherapy or?
No, we've never actually given. No, we've given sub-Q IgG.
Okay.
At home. So either they get it in the office every 4 weeks, or they get it at the outpatient section of the hospital, or they get, there's a sub-Q form, I guess, which I'm not aware of the exact name, but I know the home health people can give it sub-Q, because I've had patients get it sub-Q.
When giving the IVIG, do you set a target for IgG trough levels at all?
No, I don't. I just give it every month. And, I don't really, I get an IgG level whenever they come in to get their treatment. And most of the time, the levels are not bad. They're usually 500-600s when they come in for their treatment.
And how do you kind of assess the effectiveness?
Mostly clinical. They got less infections. Really, that's what it comes down to. They got less. I mean, really, I get the number, but if they're not having any infections and the number's 500, I don't usually, I'm trying to remember if I had anybody. I haven't had anybody where I said you should get it every 3 weeks. I think that may have come up a few years ago. I don't remember, but I think I may have given somebody once every 3 weeks because they were getting more infections, but I can't remember when it was. But it's usually every 4 weeks, and that keeps people under control.
Okay. So what I want to do now is just the last 20 minutes. We're basically looking at, the last 17 minutes. We're basically looking at the possibility of a point of care device that could assess HGG for diagnosis and also for monitoring antibody deficiencies as well. And first I want to ask you, let's imagine you had such a kind of point of care device. What do you think, would you be able to describe what an ideal point of care device might look like that could really help you sort of assess HGG in patients with immunodeficiency? And ignoring cost just for the time being.
You mean it would be a blood test, I guess. You mean a medical device? It would be a blood test which would predict which people have a higher risk of developing infections in addition to the IgG level. I mean, I guess